Welcome, everybody. I'm so happy to see you. We have two featured speakers today, Dr. David Jobs, Derek Lee. I'm really looking forward to their topic, had a little preview of that. And we have some great people on the hot seat this week. So let's get started. All right. Well, I already kind of teed it up a little bit because I was so excited. But we are going to have a guest today from the Hope Institute and really talking about treating suicide directly. And I know this is something a lot of us have been thinking about, talking about, or even doing. We're going to hear a little bit more about it today. We've got a great roundtable, and I'm looking forward to the chat. So this is a familiar slide to the jammers, but I just want to remind you, we're growing by about 10 to 15 people every single week still. So be sure and share with friends and colleagues who work in this area. We have over 3,000 people in the learning community. And again, remember, you can always go to the Crisis Jam website to review something if you were out or you missed something in a conversation, you want to recatch it. We've got everything on the website. We still have our highest one was the kind of kickoff with Miriam Delphin-Rittman on 7/13, hosted by David. But so many other great topics in there. And whenever I miss something, I'm always happy because you can see just tidbits on the website. All right, this happened to me, so I can completely relate to this picture, which was one week I woke up on a Wednesday and I was like, wow, my morning looks so open. What's going on? Then I realized, wait, where's the jam? So if you're like me and it's fallen off your calendar, no worries. You can always go to the Crisis Jam website and download the new calendar invite. And if you're at the last minute and you're like, wait a second, hold on. What's the Zoom number? I got to get on right now. No problem. Zoom link is right there at the top of the page when you go to the Crisis Talk website. So Crisis Talk website tells you what's coming up, Zoom link for today, which is always the same, new calendar invite, how to order your shirts, tidbits from previous weeks. There's so much here. Whenever I'm telling somebody about the jam and I'm trying to get them interested, I always send them to this website because it really gives them an overview of what we do on this call. So I encourage you to visit it if you haven't. Most of you probably visited, but just in case. All right. I kind of spoke about this a little bit at the beginning as well, but the 100th jam session is coming up. Now, on this call, we rarely skip a Wednesday, Christmas, Thanksgiving, etc. But we are going to skip the week before the 100th episode because it's Yom Kippur on October 5th. So don't forget, this will give you an extra week to get your celebratory outfit for the 100th jam session. And all I can say right now is that the theme is going to be the challenge that we're undertaking now that we've passed the starting line. So more about that in coming weeks, but get ready for the 100th jam on October 12th. Usual time, usual place. Now, wanted to bring up a few news things that have been going on. And I'm sure some of you've heard some of the chat out there about why we shouldn't call 988. It's, your names are being collected. It's being reported to the police, all kinds of stuff. So here's an article that was on NBC News that we've been drawing criticism, that it's police response. There was another article. Let's go to the next one. Is it safe to call? What do we need to know about the new hotline? A lot of chit chat about this. This was from NPR. And then did we have another one? So here's what I love is SAMHSA immediately responsive. Here is a new infographic they have at their website that you can start to promote to help us with this conversation. So let's look this over. About 98% of people who contact the 988 Lifeline are helped by a crisis counselor and resources shared during call, text, and chat. And on average, 9,360 contacts are coming in. Now, look at how small those slices of the pie are that relate to what we just talked about. About 1% of people who contact the 988 Lifeline work in partnership with the person they're talking to agree to have 911 called because there's a serious risk at that moment. And then even fewer than 1% of people who contact have 911 called without their consent, because they're not at a place to be able to consent at that moment, but the person feels like it's important to have 911 on the scene. What I love about this is two things. One, SAMHSA, super responsive. This infographic is easy to read, easy for us to share, and it answers a lot of this chit chat that's going on with across the board, a lot with the youth. Do I sound old? A lot with the youth around the country about what is this all about and am I going to be reported? We want people to feel safe calling 988. This also reminds me, keep going back to the SAMHSA site. There is just a wealth of new things on there almost every week that we can share to promote how 988 is used, and how it can be helpful to our audience. So keep going back. This is just an example of something new that they've got. All right. And this is kind of giving you a little tease for our Live Lens guest today. Siloan Green, here's a quote from him. Anyone can get broken, but this is the most important thing. Anyone can live. Anyone can find hope. And here he is with his tribe, kind of exploring the outdoors. We're going to hear a lot from him a little bit later, and I'm really looking forward to that. So I'm happy to say and introduce our guest today, Dr. David Jobes and his colleague, Derek Lee. You may recognize Dr. David Jobes' name. He's the developer of the CAMS, the Collaborative Assessment of Management and Suicidality. He's a professor at the Catholic University and has done really helped us move forward the work in suicidality over the last couple decades, has received numerous awards, some very early in his career and then some more recently. I'm going to hand it over to you, Dr. Jobes, to introduce your colleague, Derek Lee, and thank you so much for joining us on the Jam today.
Thank you so much, Amy. So delighted to be on the Jam today, along with my colleague, Derek Lee, who's the CEO of the Hope Institute in Perrysburg, Ohio. We are here to talk to you about the importance of treating suicidal risk, how suicidal crisis needs to move into a stabilization model, and the challenges connected to that. We've learned from Zero Suicide that we need to screen and we need a safety plan. But for a lot of people, then they're done. That they screen, they safety plan, and they think, oh, we're good. But Zero Suicide also has emphasized since its inception that we need to treat suicide directly. Now, I've been involved in Zero Suicide since the start, and to me, this has been an oversight. We don't sufficiently focus on treating suicide as the bullseye, independent of diagnosis. In Denmark, they have 5 regions, and each of those regions has a suicide-specific center where citizens can get care that's suicide-focused. Annette Erlingson's research has shown that it's effective at the national level. We should be thinking about that too. But in our country, people in crisis with suicidal crises often end up going to the emergency department or admitted to the hospital or get medicated. And each of those 3 responses may not have much evidence in support of them. Some could argue they even actually increase the risk. So getting outpatient care, as we know, is a national crisis. It may take weeks, if not months, to get locked in with an outpatient appointment. And I reckon that a lot of those folks don't know suicide-specific care like Derek and I are talking to you about today. The lifeline we know is already at capacity with a number that nobody can remember. Now that we're 988, it's going to be much easier to remember, and the capacity issues are significant for us to consider. We also just heard about the concerns about active rescue. Even though it's a very low base rate event, a lot of people, especially people of color, might have concerns about the police showing up to save them from themselves. So we have to decrease, we have a status quo that is problematic. We need to decrease suicidal suffering and save lives, but we need an alternative model to consider that. These slides move very slowly. Okay, so possible solutions. Consider using dialectical behavior therapy or the collaborative assessment and management of suicidality. Each of these interventions is clearly suicide focused with extensive literature. You can keep progressing on through this slide, please. So for DBT, there are now 44 randomized controlled trials, which are the gold standard of what works in a causal way, For CAMS, we have 5 published trials, 2 meta-analyses, and 5 ongoing RCTs. Between the two, we can stabilize patients and endeavor to keep people out of the hospital if that's all possible. And we also know that DBT reduces attempt behaviors and self-harm behaviors and treats chronic suicidal risk. CAMS reliably reduces suicidal ideation, overall symptom distress, actually increases hope while decreasing hopelessness. And on behalf of the 2 developers of these interventions, we would be very excited if more clinicians used evidence-based, proven interventions to treat people who suffer and struggle. Okay, here we go. Very slow moving. Okay, so we want to bridge the lethal gap. Kay Redfield Jamison and Richard McKeon have talked a lot about the courage to reach out for help and then the lag between getting outpatient care. So we're looking at community behavioral health as one possible outpatient care. We need something at these different levels of emergent care, urgent care, and routine care. When people reach out for 988 in crisis, ideally they get a mobile crisis response, but they also can go to crisis facilities. But the Hope Institute that you're hearing about today can fit in at each level with emergent, urgent, or routine care. Next slide, please. So I'm going to turn over to my colleague, Derek Lee, to talk to you specifically about the Hope Institute. Derek?
Thanks, Dave. So I want to start off by touching on the last slide that was up, because this is a key piece that's so important. I think a lot of people think about what we replace in the system, and the idea is not to replace anything in the system. It's to augment the system. It's to help the system. I'm coming to you today as a clinician. I also teach and am involved in research, but I consider myself a clinician first and foremost. And I've worked with suicidal patients for about 15 years. That's been my specialty. And this is coming from a need. We were really good at getting people in 3 days or less up until COVID hit. And when COVID hit, we, like everybody else in the country, went to a backlog of 3 and then closer to 6 months. That's not okay when you're working with individuals struggling with suicidality. So we had to figure out another way to get people in, which is how the Hope Institute came about. And the Hope Institute isn't just for those emergent cases, it's for people coming out of the hospital that need that initial assessment. It is for the routine clients coming in, but it's for urgent. So we're really about helping all systems and taking the burden off the systems to create stabilization so that people can wait, whether it's 3, 6, 9, 12, 15 weeks, but giving people that time so they can get into the ongoing care that they need. Go ahead and please advance the slide. So our first office is in Northwest Ohio. And some of the things that we are offering and have been offering are next day appointments, where our goal is to get people in within 24 hours. Quite often, if we get a call in the morning, we're able to get people in that afternoon. We really are rooted in evidence-based care. It's CAMS and some group skills that have been modified from DBT to accommodate the model. But the goal is to be able to stabilize people quickly so that they can take that time that they need to get ongoing care if needed. When we talk about stabilization, we're showing an average of 6 weeks for adults and 5.2 weeks for the child and adolescent population. And again, the Hope Institute is only doing the stabilization piece. So we are still counting on the current community mental health centers and outpatient providers to do that ongoing work. This is simply a stabilization center. When we start looking at where our referrals are coming from, it's varied. We've been in the community for a lot of years, and we're known for working with this population. So we've had existing relationships with some local hospitals, and that includes both emergency departments as well as the inpatient unit looking for outpatient care. We're also working with our history corrections. So a lot of juvenile probation, but also adult probation. And I've been in conversation with some sheriffs. Schools, we've got a long history of schools. We've got some we work closely with, but we work with almost all the schools in our region. First responders, police officers, firefighters, churches, community behavioral health centers. And we've recently started working with our crisis line here, which is hosted by Unison. And they're turning, I think they're going to be a great partner for us. And when we talk about stabilization, I think one of the most important pieces of this is getting results. And one of the best results I can tell you is that so far, of the 418 people that have come through the Hope Institute, they're all still walking this earth today. That's what makes me smile. That's what makes me happy. So our referrals so far have traditionally been word of mouth. We've been part of the community as Perrysburg Counseling for a number of years. So people know us, they know our facility, they know a lot of our clinicians. But the word of mouth has brought in roughly 418 people. The numbers are a little bit higher at this point, but also the rapid stabilization times. Again, I threw these numbers out with adults being 6 weeks and the child and adolescent population being 5.2 weeks. It's fantastic. And when I say that, I'm going to jump to the next stats. Roughly 15% so far have not needed ongoing care. And this ties into something that resonated with me in a meeting with Richard McKeon a while ago, stating that, according to SAMHSA's numbers, roughly 38.5% of individuals don't actually need ongoing care. They need stabilization. And we're starting to see that reflected in our numbers. And I think that's really, really key, because we've got a community mental health system that's already overburdened. I don't know anybody that doesn't have a wait list. And this is starting to maybe alleviate a little bit of that burden. We are trying to do follow-up calls every 3 months just to make sure that people are okay, and that'll go on for the first year. But the 85% that are stabilized are now available to wait for those outpatient clinics. And they always have the opportunity to come back if needed. Ahead and advance, please. So when we talk about this, it's about complementary systems and each one being essential. So when we talk about the Hope Institute, what we're trying to offer are next day appointments, some things that people aren't able to do in the community. And when I say that, I'm going to quickly illustrate that your typical 6-person outpatient center is going to take on clients, and a lot of your clients that are suicidal are going to be a little bit more intensive. So say you've got each clinician taking on 25 clients, 25 times 6 is 150 people that have been served that year. Because we're stabilization, we have a turnover that averages 5 to 6 weeks, which means we're able to see in excess of 1,000 people a year with that same number of 6 clinicians. So it really is about us complementing the other systems. With that, we're also able to provide multiple appointments to each client during the week, and that's a combination of individual and group sessions. And this can be really important, especially in this day and age and in COVID, because we were working with people who were homebound. They weren't getting out, they weren't going to school, they weren't going to work, or they were doing those things from home. So just that socialization piece can be really important for people who are struggling with suicidality. And again, I think, what we're doing in stabilizing so quickly really puts people in a different place from hopelessness to hopefulness. And then as they move on from the Hope Institute, they're able to move on to those community mental health centers to deal with the underlying issues. That's something that we are not doing, and our intention is not to staff the Hope Institute with ongoing therapists. It's to really focus on that crisis work that we do well. So once stabilized, they can wait out that maybe 3 to 4 or 5 months until they can get into those community mental health centers. So I can advance the slide. And one of the key pieces that I think gets overlooked with a lot of models are clinicians. I will tell you, I'm nothing without the staff that's behind me. I've got one of the most amazing staffs in the country, and they're the lifeblood of what we do. They're the people that are actually connecting with our clients. They're the people that are actually delivering the hope or creating the hope with them. And we have to build systems that are really supportive of our clinicians. So, just talking on a very basic level about the moral and ethical care that not only takes care of the clients, but the clinicians, and a focus on clinician well-being. We talk about it a lot, but we have to really do it. And that means pushing that people take vacation, not discouraging it because we need the clinicians in the office, but having vacations, having things to boost their morale, activities, and just a really positive office environment. Competitive pay. This has been an issue in our field forever. But it really is important, because if we're expecting helpers to help others, they shouldn't have to go home and worry about how they're going to afford to put their, to allow their child to play hockey or softball. We've got to be able to give them a reasonable living, which we've been able to do at the Hope Institute. We also have a structured approach, which we've taken from the DBT side of things. I've been a DBT clinician for about a decade, and DBT provides a lot of structure for the clinicians and the team, which helps build chemistry and support in itself. The way we handle things also, we've got administrative individuals, myself in particular, that help deal with attorneys and documentation and liability. And it's one more level of protection for the clinicians. A call from a lawyer can be really stressful. Working with suicidal individuals can be really stressful. But when they're given the right supports and the right tools to do it effectively, the liability really does go down dramatically. And that takes a lot of stress off the clinicians. And we have to remember that our clinicians are doing life-saving work. And if we can pull some of those things back and let them enjoy that, it reinforces the great work that they're doing every day. So, our goal really is to build a culture that supports the career of a helper and helps them to thrive in the face of crisis. So when we talk about, a vision for the Hope Institute, it's really about next day appointments with evidence-based treatment. We're also trying to do what we always talk about in the world of counseling and psychology, is provide a least restrictive environment. A lot of individuals are put into hospital situations that might not need to be, or they're not being cared for in the way they need to be. But we can provide them the care, and we can also do it in a least restrictive environment. We're talking about rapid stabilization and resolution of suicidal ideation. And I think that piece, resolution, is really important, because it doesn't necessarily mean that they will never deal with a suicidal thought again, but it means that they're able to effectively manage it. Another key piece is increasing access. And when we talk about access, a lot of this is coming through telehealth, but it's also in dealing with a variety of insurances, so that not only the wealthy or the people with premier insurance can provide these services. It's about making sure that they're accessible to everybody. I mean, we talk about human rights, and I know healthcare and rights are a touchy topic, but I think everybody has the right to live. And suicidal services really are about the right to live and the right to help everyone, regardless of location, financial backing, color, race, creed, culture. We need to make sure that everyone has access. And also, it's about the destigmatization and decriminalization of mental health and crisis services. We've done a lot in our field to try to promote that. And I believe that this is another step in that process.
So there you have it. That's our model of a way of bringing evidence-based care to people who suffer and struggle. The Hope Institute website is here. You can contact Derek directly, and I think we'll turn it over to our discussion group.
Actually, before we turn it over to them, let's keep your slide up with your names, but I wanted to just have you clarify a couple little things that are coming across in the text before we turn to the roundtable. Can you just speak for a minute about what is CAMS and what is DBT in this context? Oh, we have a lot of people on this call who are delivering care, and they want to know a little bit. Can you just expand a little bit on what those are?
Yeah, they are two evidence-based, people toss around evidence-based like it's ubiquitous, but really there's only a handful of interventions clinically that have been proven to be effective in a causal way. The king of the mountain is DBT, dialectical behavior therapy, which is a component of which is in the Hope Institute. There's a ton of research supporting this, and CAMS has also extensive literature in the support of it. It's a collaborative approach. These are patient-centered approaches. They validate the patient. We try to keep people out of the hospital. And we're mostly doing that by building skills or helping to stabilize them. In short, that's what we do. And they work.
Wonderful. Yeah, which is critical. I know that if someone were to Google your name, Dave Jobs, Catholic University, when they find you, there is a nice upper nav that talks about what is CAMS, what is our research, how can you find out about it, what can you do? So that's easy. And of course, you can always Google dialectical behavioral therapy or Marsha Linehan and find out about DBT. So it's pretty easy to find, but important for us to know that these are two evidence-based practices in this area, and there aren't that many. So it's good to know about these. So appreciate that.
Yeah.
All right. So let's turn it to our roundtable. So happy to have these two folks today. So Karis Myrick and Dr. McKeon from SAMHSA. Happy to have both of you here. And I will let you two kind of reflect on the conversation we had today.
Should I start?
Sure. Yeah, that'd be great.
So I should also say that the podcast is my side. I want to say it's a side hustle, but there's no hustle there. It's just a side thing. My thing is I am the vice president of partnerships at Inseparable. That's my day job. But, in response to this wonderful presentation, I want to thank you for focusing on the idea of augmenting care and not replacing care. I think that's really important when we talk about that. Some of the questions I have, which I didn't put in the chat because I know I would be speaking, is a lot of times when I'm looking at presentations or trying to understand work, and the first thing I hear is evidence-based, I want to know who it's evidence-based on. You can look at me if you can see me. I am a Black Native woman. And so I'm always curious, how is this evidence-based for Black and Brown and other people of color, people who are LGBT, identify as LGBT, et cetera, because a lot of the evidence-based practices were not normed with these communities in mind. So that's the first question that always kind of comes to my mind. And we know that, even CBT and DBT sometimes are not effective for communities of color, for people of color. So I think those are some questions that are not to negate the importance of this kind of approach. I also think it's means where and how can we get more research focused on these communities using approaches in which they have not traditionally been focused on. We know that Black adolescent suicide, the rates are very, very high, disproportionately high, have increased over the past decade. And it's the second leading cause of death for Black youth, suicide is. So I think understanding how CAMS Care and Hope Institute provide the type of culturally relevant, culturally competent support for Black youth and communities of color. And also the involvement of peers. I can't say enough, and people know, I'm going to go there, that, as a person who themselves has been given a diagnosis of a mental health condition, is a suicide attempt survivor, the most important thing that I could ever say that helped me was meeting somebody who looked like me, who had been through what I had been through, to have the belief that recovery was even possible, who understood the social constructs, discrimination, racism that can impact and affect our mental health, lead to hopelessness, self-hatred, all of that kind of stuff, that medication can't fix that. Sometimes therapy can't fix that. But what can fix that is understanding that, yes, it does impact your mental health. And when we fight together to eliminate these structural barriers, if you will, it leads to hope and recovery as well. So I'm very curious about any studies or future studies that look at this particular practice in communities of color in particular. Thanks.
Why don't we go to Dr. McKeon, and then we'll swing back to the faculty to let them have a chance to respond to some of those very important points.
Thank you. Glad to have an opportunity to comment on this important model. David mentioned the groundbreaking work of Annette Erlingsen in Denmark, which showed that referrals to their specialty suicide prevention clinics were associated over a period of, I think it was about 20 years that they did their follow-up, with reduced deaths by suicide. And, you know, a lot of that seems to, particularly in the early years of the Danish work, I think really revolved around the fact that they were seeing people who worked with suicidal people all the time and did not get anxious, did not panic, did not immediately send people to the emergency room or call the police, because the therapist was trained and experienced and able to work with and to not become panicked by the suicidal thoughts that they were experiencing in therapy. I think that that's really important, because the people who are providing the therapy, it's really important that we pay attention to that they're trained, that they're working with some protocols so that they are not automatically sending people to the emergency room if they mention the word suicide. There's also work from England, Nav Kapoor, which shows that mental health facilities that have higher turnover rates have higher rates of suicide deaths, right? So in a way, it's intuitive, you know, that if you have a mental health setting that's in turmoil, that the work that they're going to be doing is not is going to be as good. So it's something that I think we really need to be paying attention to. And one of the virtues of this model is that, you know, you have therapists who are trained in and comfortable with working with suicidal people, whether they're using DBT or whether they are using CAMs. I think there's a real advantage to that. And of course, the use of evidence-based treatments is a part of the zero suicide model. But something that's not a part of the zero suicide model, but is a part of this model and is critically important now with the universal availability of 988, is a rapid access to care. And we know that this is a problem in many places all across the country where there is not a protocol, a procedure, a way of getting people with suicidal thoughts into care quickly. So there are two components to it: getting people into care quickly and then getting them into the right care. So I think this model has a lot to recommend it, because it really tries to combine both of those two aspects. And this will be really important, that as we anticipate the numbers calling 988 continue to increase, right? The people who may not need a mobile crisis visit, but will need to get into care quickly, that's going to be vitally important to be able to be done. And so that the question of connecting to care, I think, is an area that requires a lot of attention now. And this is one fascinating potential model.
Thank you, Roundtable. You know, one thing I'm hearing is both the line of building the continuum of care and also having that continuum of care be something that our audience feels comfortable accessing. And I appreciate Karis pushing us again to think through, just like we're having lived experience lens now, we're having speakers, we're constantly, as we pass the starting line, we really need to keep layering in, how can we reach everyone, right? How can we be open and help everyone who is in need? I don't know if Dave or Derek wanted to respond at all. I know you guys have been responding on the chat. Was there anything you wanted to kind of highlight?
Just very briefly, that a meta-analysis has shown no differences for CAMs being used across different populations. And we have a specific study that we're launching with Sean Joe in St. Louis, focused on Black teens and LGBTQ plus teens as well. So I totally agree. We need more focus on diversity and marginalized populations, and we're after it.
Right, great. We appreciate that. And I think, again, I really recommend folks going to the websites, finding out more about CAMs and DBT, and continuing for all of us to open our eyes to our full audience who are in need of care, a continuum of care when they're in a crisis, mental health crisis. And Kara, sorry that we left off your other title. I had actually just recently seen this on LinkedIn, your new job. I was really excited about it. But it's hard for me not to post up about your podcast, because it really is an amazing podcast. And if folks in the audience haven't listened to it, I really recommend it. Follow her on LinkedIn and you can see the new topics each week. All right. Boy, I know you're really sick of me hawking Jam t-shirts, but I'm going to hawk them one more time. So get your Jam t-shirt. One thing I want to point out, so I am a person who, I actually have two now, and wanted to point out shirt number 4, where you can see there, it used to say someone to call, someone to come, and wait, let me look at my shirt that I have here on the side. Someone to call, someone to come, and somewhere to go. Well, notice we've made a little change here. Now it says someone to call, someone to call, someone to come, and a safe place to go. Just kind of hanging that out there for something we're going to talk about in a minute. Anyways, think about the t-shirt you want, what you want on the front, what color you want on the back, what size you need, whether you want it in Spanish or English, and get your order in. We really appreciate the support. All right. So I am excited now. We are at the hot seat moment, and I'm going to call forward Dr. Trevino. I see you. Hello, welcome.
Hey,
good to see
thank
you.
you for having me.
Hey, I'm
Thank
so
you.
excited. You're the medical director at the Ohio Department of Mental Health and Addiction Services currently. Is that correct?
They call me that sometimes, and I try to do that every day. That's yes,
Okay.
Thank you.
Wonderful. Well, welcome. So
Thank
let
you.
me read you the question. Good news. I think you've been on the Jam before, but remember, you can phone a friend. We're going to give you the audience's guess, and you can talk through it and think through it. So here we are. Dr. Anita Everett first used the phrase someone to call, someone to come, somewhere to go in the SAMHSA November 2018 Hotline Improvement Act planning meeting in Bethesda. But as I mentioned before, it's been amended. Who was the person who amended this quick phrase for the 3 core services and said as the third one, a safe place to go? Was it Dr. John Draper's group in 2019 at the IMHL Crisis Now Summit? Was it Dr. McCann's CATS team at the 2020 SAMHSA National Guidelines? Was it Dr. Deb Peinels, who's on our call today, at the 2021 NASHFIT Beyond Beds? And by the way, you cannot call her and ask her. And Melinda Baldwin's team, or was it Melinda Baldwin's team at the 2022 SAMHSA Youth Guidelines? So we've got different years, different people, all key people in the discussion around 988. But let's see what our audience has to say. And then you can think about whether you want to use that or you want to phone a friend. Let's just get a minute here. It's going to come up. What are your initial gut reactions? Oh, here we go. Oh, this is the worst when it's a divided audience. So you've got D is leading, but you still got a quarter of the audience for Deb Peinels and a quarter of the audience for John Draper. What are you thinking, Justin?
Justin has his 988 team here, and I do want to say who they are. So I have Bobby Boyer, who is our deputy director in our Office of Prevention Services. Stacy Fronhapel-Hassan is our 988 person to go to. She's our chief in our Office of Prevention. Doug Jackson's our 988 administrator, and Abby Wolfschlager is our 988 QI person. And we have 19 certified lifelines in Ohio. So they're going to help me answer this question. I didn't trust technology here. I had to bring
I hear
people.
you. I
And
hear
to bring
you.
them with me. So we're going to do 1 minute and say, who do we think? Who do we think?
I love it. You brought your own team. I mean, that's the way to do the hot seat. What are you thinking?
It's Melinda Baldwin.
All right, we're having a hard time. Yeah, we're having a hard time going against the audience. And I know Deb Peinels, and I chose her, but we're going to go against Deb, and we're going to go with the audience number, Melinda Baldwin.
Okay, D. Melinda Baldwin. Let's see if you were correct. You earned your t-shirt today. You got it correct. Yay for your team.
I
So
say yay for my team.
yes, each of these efforts have contributed significantly. Everybody on this list has been an important component to our language around the next generation crisis system. But it was the group adapting the national guidelines for kids, which added the language, a safe place. So this is very important. And we've been talking about this over the last few weeks about, we've talked about adjustments to our youth. So this is really good. Well, congratulations. A t-shirt is on its way. Very excited to have you today. Thank you so much.
I will look for my safe place to go in, and our team will give each other high fives. Hey, thank you guys for having us. Really appreciate it.
Thank you so much. And just a reminder, one more plug. If you want to be in the hot seat in a coming week, we'd love to have you. Feel free to submit your name. Look up in the chat, or we'll put it in the chat again for a way for you to submit your name to be on the hot seat. All right. Well, I'm calling forward Stephanie Hepburn. So excited you're feeling better and back this week. Yeah. Talk to us a little bit about your interview with Dr. Copeland, and I think she's here with us today as well.
She is. So yes, I wanted to introduce Dr. Mary Ellen Copeland, and she developed the Wellness Recovery Action Plan, which is a self-empowering and evidence-based practice. Mary Ellen, if you can hop on the call or can join me, can you let me know what was the impetus? What actually began your research into developing this plan?
I have to kind of correct that. I didn't really develop the plan. The impetus for it was that I developed a body of knowledge that back in the late 1980s, I became really aware that nobody was looking at all of the people who have recovered from mental health issues, and the people who work on them constantly. Nobody's asking them what helps, what works for them. And so I developed a research project and did intensive research over several years. And then I began giving workshops on all the wonderful things that I learned from people on how they addressed mental health issues. It was one of these groups, a woman stood up and said, this is all well and good. You're teaching me all wonderful things to do, but I have no idea how to organize it into my life. Mm-hmm. And her name was Jessie Parker. And those of us who were working together, leading the workshop series, it was a series of 8 sessions, decided that we needed to really listen to that and to develop some kind of an instrument that people could use to really take all the recovery information that they were learning and put it together into a life plan. So that group of people, there were about 25 or 30 of them in a room, we worked together over a number of days, hashing this all out. We first talked about all the things, the wellness tools that we can use to support our wellness, simple, safe, effective things, getting out in nature, exercise, working with our diet, talking to a friend, doing peer counseling, focusing exercises. They decided that they need a list of those, and then they needed to use those to build plans for what they need to do every day to stay as well as possible. And then what do they do if something really upsets them, and to develop a plan for that. They needed to make a list of early warning signs, things you don't realize anything's going wrong, but all of a sudden you're starting to feel really not well, that you're starting to feel your mood is low, you're feeling like you don't have any friends, you're feeling really badly about yourself. I might have a headache. For me, I was noticing that I wouldn't snap my seatbelt, and I wouldn't look both ways when I crossed the street, were early warning signs for me. And then we took some wellness tools and we made a plan. This is what I have to do when I feel that way to get myself feeling well. The next part, which I think has become the most important part of RAP, is when things are breaking down. And this was people identified, this is the time when I am almost at a crisis. I am almost there. these are the signs that indicate that. I'm yelling at people, arguing with people. I'm doing things I wouldn't normally do. I'm eating everything in sight, or I'm not eating anything. I'm sleeping all the time. What do I do then? And they came up with very strong plans. People come up with great plans for what they can do at that point to move themselves back into feeling well. And that's, for me, that's the most important part of my rap. And that was the most important part for people. And then they developed a whole crisis plan, which is very self-directed, and a post-crisis plan. They did all that work together. I took the plan home and developed my own and said, whoa, this is great. Things really changed for me because I had mental health issues myself. And and since that time, that's 25 years ago now, that group up in northern Vermont in the winter developed that plan. And now it's being used literally all over the world.
And with a variety of groups, I believe, right? If you could talk a little bit about, you mentioned people who've been incarcerated are using the plan, people with diabetes. It's really, for you, you said for you, it's a lifestyle, and that's what it's turned into. Can you talk a little bit about that?
Yeah, it has become a lifestyle for people. It's something that I think about every day. And actually, I had a friend contacted me. We're in touch regularly, and she said to me, "Are you using your rap? I have a brother who's very, very sick, and so that's a trigger and a stressor for me. So I need to be following that particular part of my plan because I'm upset about what's going on with my brother. He's been sick for quite some time. He's in the intensive care unit. So I have all these things that I do, and people are using them to get through all kinds of situations. They're using them to address trauma in their lives. They're using them to work when they get a job. They first get a job and they're really, it's really hard. They're using it for those kinds of issues. People are using it when they have signs like hearing voices and feeling really agitated and feeling very stressed out. Virtually all circumstances, people are using it to manage if they have small children, if they're care providers, if providing care for elderly people in the home. It's just become kind of across the board, but it really started in the mental health community and was developed by a very courageous group of people who were experiencing really extreme mental health issues themselves.
And I like how you talk about in the article how it's self-empowering, but I also like that you talk about how people can support one another. So, for example, in a plan, you talk about, when does somebody, a family member, step in? How can they be supportive? And you yourself navigated revisiting that. It's like a ever evolving process where you learn more and you can amend and change the plan to best suit you.
Absolutely. So you're the first parts of your rap are yours alone. But when it gets to the crisis plan, when people are having a really difficult time, people develop this plan for themselves, and they develop it when they're doing okay. And then then their supporters can use that plan when they're not doing so well, and they get to name who they want to follow the plan when they're not doing, when they're in a crisis, and they get to name the signs, what indicates that they really need somebody to step in. For instance, if you're unconscious, you really need somebody to step in. Or if you're breaking the law, if you're normally law abiding and you're breaking the law, if you're not staying at home, you're refusing to go home might be an indicator. People write that down. For me, it might be, am I washing my face over and over again so that it's red and raw? Am I just constantly washing my hands? Am I getting really irritated with people in a way that I normally wouldn't, that's really hurtful to them? Am I taking chances? Am I taking risks? Am I spending way, way more money than I have? All of those kinds of things are on my list and then in other people's lists. And then they have a clear list. Who do I want to help me? And then who do I not want to help me? There's certain people in your life who you may love very much, but you don't want them involved at that time.
Well, thank you so much for hopping on the call. This is a really important article, so I hope people go and check it out. Thank you. Back to you, Amy.
Great. I'll just say to Dr. Copeland, there's a lot of fangirl and fan guy in the chat. Everybody is so thrilled to see you and hear your firsthand account about how RAP came about today, because many of us have been trained or used it ourselves or with clients. And so really appreciate you being on today.
Thanks. Thanks so much.
Next slide. So Siloan Green is here, joined us today. I saw you down in amongst all the boxes of people. So happy to see you. You know, in the last few weeks, we've really been thinking about, you know, we have this analogy that what we're on, we just started at the start line, right? When we got 988. And one of the things that we're really trying to think about is, even though we know it's a ways away, what does the endpoint look like when we really are doing this well? And so we sort of have this visual here of base camp and all the things that we see along the lines that we would like to be part of the continuum and to allow everyone to feel a welcoming place for them when they're in a crisis. And I'm so happy to have you here today, learned a little bit about you from our team, and I just wanted to welcome you and hear a little bit from you today, Siloan.
Good to be here with y'all. Hey there, David, Karen, and Lisa, my friends. I saw you somewhere in the chat. You know, I think the kind of the main point I wanted to get across, David sent me a text kind of saying that, you know, what, from your lived experience, looking long term, what would kind of be a pie in the sky outcome of 988. And to me, it's connection. I mean, if you're lonely, in a lot of ways, it does not matter what therapy you get or what intervention you get. If by the end of that course, you're still lonely and you're still isolated and you're not connected with people, you're probably still going to struggle. And I look back on my own recovery and my life and where I'm at now, you know, and even the psychiatrist that initially helped me, you know, my memory of it is mainly the relationship I had with her. It was feeling connected with her. I liked what someone said earlier, you know, looking him in the eye and feeling like, hey, you're going to get me through this, or you've been through this. And, you know, something that's happened over the last 20 years is more and more has been done about suicide. Our society has gotten more and more disconnected. It's normal for people to live someplace where they don't have any friends, have any family. And I think it'd be cool if 988 kind of became a resource that not only was it, you know, a resource that got you connected with mental health professionals that, you know, in that acute crisis could help you, but it was also a way to connect people. That part of that system, you know, you called, you got handed off to somebody, and then part of that system, that sort of continuum of care, that long-term journey, that the end of it was helping that person get connected where they are with whatever they need. You know, it could be a church, it could be a sports group, it could be a YMCA, it could be, you know, a million different things. And, you know, I think universally, when I give a lot of talks, when, you know, people come up to me who are struggling with this, you know, universal sort of condition of them I see, and again, it's just anecdotal, but they're lonely, they're not connected. And it's amazing to me where you get a room of people together and you're giving a talk and you get a little bit of feedback, and then all of a sudden you have people in that community that you sort of developed, you know, in that situation that you're in. You know, they're coming forward and they're saying, hey, I need help with this, or I need to talk about this. I just did a talk recently at I probably can't specifically say, but it was a very high profile military facility. And there was a room full of people, been through a lot, military types. And, you know, none of them have grown up within hours of where I was. You got 50 individuals with no family, no friends around. You got people that are afraid to come forward to mental health, afraid to talk to a chaplain, afraid to talk to a counselor. And we spend a couple of days together and we're talking, and I'm sharing stories and I'm getting them to talk. And the result of that was at least 3 people that I knew of got help. At least. I mean, at least 3 of them said, you know what, this is normal. I should get help with this. And I'm going to go get help. And then, you know, one of them did it by like, I need to take buddies of mine shooting more, you know, because they're military types, or, I need to go out to beer more with my team or whatever it is. We need to get together as a community. So if there was some way that the 988 vision could include helping people get connected with their communities that they're in, so they have long-term relationships, that would be awesome. And then one more thing I just wanted to share, because I know anti-stigma is a big part of all of this. Something that I have found, I go all over the country, give talks weekly, that a term I have found that especially people that I talk to, a lot of law enforcement, first responders, military veterans, a term that I've been using for years and I find really gets people thinking about it in a more healthy way, is I use the term mental fitness. Hey, say mental health is mental fitness. You're going to go to the gym and you're going to get stronger. Why not go see a counselor and get stronger? Why not talk about these issues you have and get stronger? So anyway, connectedness.
I love that. I worked in the VA for 18 years before I changed my current job. And there is nothing like the kind of peer connectedness in the VA. Veteran to veteran, I found that amazing. And I find that now that I'm out of the VA with peers, and I have found that. But one of the things you're talking about is kind of leveraging a person's strengths, interests, hobbies, etc., and finding a place for community with those as well. Like you said, church, sports teams. I once had a friend who loved to make sailing knots. Turns out there's a whole group on Facebook who like to do that as well, right? And so there is a kind of a place for all of us and a couple circles that we fit in. And so making sure that us and our friends and the people that we work with have a couple of circles, I think is a really important point that you're making today. And I really appreciate hearing from you and learning more about you as we were preparing for today's talk. So thank you again for being on the Jam.
Yep, great being with you.
I'm going to turn it over to SAMHSA, John Palmieri. Happy to hear from you.
Hey, Amy. Hey, everyone. Thanks. Good to see you all. I'll be brief here. I know we're running out of time here, but I really appreciate the comments just now on connection. It does tie in very nicely to what we are working on currently with respect to a crisis care plan of action, which is required as part of our FY22 appropriations, but very much thinking front and center about 988 and where that fits into a broader continuum and is reflective of sort of an individual journey throughout the care system. So a lot of work happening across the federal landscape on that document. Also, SAMHSA is taking a lead on a couple of the sections on the executive order that was passed in May, that was put forward in May on accountable policing and criminal justice practices. So there'll be some work coming out of that collaboration with DOJ and other federal partners. Also just wanted to flag ongoing updates. Thank you, Amy, for highlighting this earlier. Updates to the toolkit that people should continue to look and reference the 988 website. There'll be additional materials forthcoming, and we're continuing to evolve and update that based upon what we're hearing from the field. So keep the feedback coming. We greatly appreciate that and rely on it. And then finally, getting very close to being able to release some more specific data on the first full month following 988 implementation, which would be the month of August. So hoping that we are going to be able to get that out the door very soon for everyone's kind of awareness and visibility. And I think that's it for me. Richard, I think, is still on the call if you have anything else you wanted to add.
I'm just going to add one thing. I had the pleasure of being at the European Suicide Prevention Symposium, and Meret Nordentoff, who's the lead on suicide prevention in Denmark, did a fascinating plenary using a methodology called population attributable risk. But according to the Danish data, if you focused on 4 different populations, you could reduce suicide in Denmark by 49%. Those 4 populations were inpatient discharges, emergency department discharges, suicide attempts, and people who called hotlines. The number that they estimated for people who called hotlines was about 9%. So if you could reduce to this level of risk of the population as a whole for those 4 populations, you could have that kind of reduction was our main point. So it was fascinating. And obviously that's part of what 988 is about.
Wonderful. Thank you, Samsa. And off to Dr. Pinel's update from Nashville.
Okay, well, in my 2 minutes that I have, or maybe even less, just want to give a preview of coming attractions. We've got the Nashville papers that are about to go on to the website. They're being reviewed at SAMHSA right now. Wanted to highlight one that really fits in here. Remember, the theme is from crisis to care for the 10 papers, which fits right into what John Palmieri was just saying, and the theme of what everybody's talking about, their RAP plans and everything. The paper that I wanted to highlight today is about lending hands, really thinking about how the partnerships work with police, mobile crisis, EMS, what's going to happen on the scene, all the different elements that we have to think about related to the legal regulation of crisis response, making sure that we meet constitutional requirements, least restrictive approaches to people, and how together we can, by lending hands to each other, be smarter about policy and practice to achieve better outcomes. And that's all I want to say. It will be on the Nashville website fairly shortly.
Wonderful. As we know, it's Suicide Prevention Week, episode 6 of Moving America's Soul on Suicide. Look for it out this weekend. It's coming. One of the themes that's been on today is this idea of caring for those who care for others. And so if you were interested in that today, definitely join us next week with Dr. Moutier, who's going to be talking about caring for our own. You can see a number of other topics coming up. And thank you everyone for joining us today, and we will see you next week. Remember, I like that term, mental fitness, that we learned today. Good luck to everyone and have a wonderful week. Thank you.